Welcome back. Doing some Irvin Yalom today. From his handy book, The Gift of Therapy. Great read for therapists, easy to read, full of wisdom. But there's some perhaps useful stuff for laymen as well. So let me get the quotation here. From chapter 2, early on in the book, and the chapter is entitled Avoid Diagnosis, except for insurance companies. So I'm going to read most of this. I'll skip over maybe a little bit, or perhaps I'll just read the whole thing. It's not too long, and then we'll talk about it. Today's psychotherapy students are exposed to too much emphasis on diagnosis. Managed care administrators demand that therapists arrive quickly at a precise diagnosis and then proceed upon a course of brief, focused therapy that matches that particular diagnosis. Sounds good. Sounds logical and efficient. But it has precious little to do with reality. It represents instead an illusory attempt to legislate scientific precision into being when it is neither possible nor desirable. Though diagnosis is unquestionably critical in treatment considerations for many severe conditions with a biological substrate, for example, schizophrenia, bipolar disorders, major affective disorders, temporal lobe epilepsy, drug toxicity, organic or brain disease from toxins, degenerative causes, or infectious agents. Diagnosis is often counterproductive in the everyday psychotherapy of less severely impaired patients. Why? For one thing, psychotherapy consists of a gradual, unfolding process wherein the therapist attempts to know the patient as fully as possible. A diagnosis limits vision. It diminishes ability to relate to the other as a person. Once we make a diagnosis, we tend to selectively inattend to aspects of the patient that do not fit into that particular diagnosis, and correspondingly overattend to subtle features that appear to confirm an initial diagnosis. What's more, a diagnosis may act as a self-fulfilling prophecy. Relating to a patient as a, quote, borderline or a hysteric may serve to stimulate and perpetuate those very traits. Indeed, there is a long history of iatrogenic influence on the shape of clinical entities, including the current controversy about multiple personality disorder and repressed memories of sexual abuse. And keep in mind too the low reliability of the DSM personality disorder category. The very patients often engaging in longer-term psychotherapy. And what therapist has not been struck by how much easier it is to make a DSM-4 diagnosis following the first interview than much later, let us say, after the 10th session, when we know a great deal more about the individual? Is this not a strange kind of science? A colleague of mine brings this point home to his psychiatric residents by asking, if you're in a personal psychotherapy or are considering it, what DSM-4 diagnosis do you think your therapist could justifiably use to describe someone as complicated as you? In the therapeutic enterprise, we must tread a fine line between some but not too much objectivity. If we take the DSM diagnostic system too seriously, if we really believe we are truly carving at the joints of nature, then we may threaten the human, the spontaneous, the creative, and uncertain nature of the therapeutic venture. Remember that clinicians involved in formulating previous, now discarded diagnostic systems were competent, proud, and just as confident as the current members of the DSM committees. Undoubtedly, the time will come when the DSM-4 Chinese restaurant menu format will appear ludicrous to mental health professionals. Well, for some of us, it already appears ludicrous. For heaven's sake, there are experts that considered it ludicrous before I was even born. And note that this is referring to the DSM-4 when now we are at DSM-5 of an ever-expanding book of labels. So there's a lot to say about this. There are things I agree with and things I disagree with actually as well. So Yalom is certainly right when it comes to this overdependence on diagnosis, and I would perhaps be far more, for lack of a better word, extreme in my criticism, in that, and I have written about this previously, and there'll be past and future videos, I'm sure, detailing this in more, detail regarding the bankruptcy of these claims of validity and reliability when it comes to psychiatric diagnosis. But yeah, Yalom is right that they can end up creating a self-fulfilling prophecy. They can prime you to be looking for confirmation of behaviors, statements that conform to the label that you've already applied. So obviously that is a problem. And yeah, he's right about the reliability too, and the DSM-5 didn't fix this. It is also not reliable. I'll do a whole video talking about a book called Mad Science that exposes this. But as I've said for a long time, even perfect reliability does not actually matter if the thing itself is not valid, is not a valid entity. Which is why I don't think there needs to be any reliance whatsoever on these labels. So I would actually go further than Yalom, because he slides in this little caveat, if you noticed early on, where if you look at the chapter head, avoid diagnosis seems pretty clear, right? And he explains why they're not all that scientific and the problems in how it affects the therapist once you make that diagnosis in terms of how you relate to the person you're working with. But as many people do, he gives this caveat to say that, it's not all bad and there are times when it is needed. And this is what bugs me when people do this. Because just to zoom in on this particular paragraph. So after he makes this initial statement saying they're not that scientific, he provides this caveat, just to repeat it. He says, though diagnosis is unquestionably critical in treatment considerations for many severe conditions with a biological substrate, and then in brackets he gives examples: schizophrenia, bipolar disorders, major affective disorders, temporal lobe epilepsy, drug toxicity, organic or brain disease from toxins, degenerative causes, or infectious agents. And then close parentheses, and then he finishes by saying diagnosis is often counterproductive in the everyday psychotherapy of less severely impaired patients. So, okay, a couple of things here. The first one, and this often happens, a lot of psychiatrists do this, and even in the DSM I think they do it too, where they smuggle in legitimate neurological disorders or issues with psychiatric diagnoses. These are not the same. Something like epilepsy is there is a legitimate issue in the brain that can be pointed to. And something like drug toxicity, obviously, that's measurable. Organic or brain disease from toxins, again, something measurable. Degenerative causes, I assume maybe he's referring to something like Alzheimer's or infectious agents. So again, these things a neurologist can test for and measure, and there is a physical symptom or a lesion that can be pointed to. Now this is how, again, a lot of psychiatrists, they muddy the waters, because they smuggle that stuff in, or they smuggle psychiatric diagnoses in with this stuff. So earlier on, before those, Yalom mentioned schizophrenia, bipolar, affective disorders, as if these are just as biological as something like epilepsy, which is absurd. The chair of the DSM-5 admitted this over a decade ago, that they're still looking for biomarkers for any of this stuff, including schizophrenia and every other psych diagnosis. And today, there is no laboratory test to distinguish a so-called schizophrenic from a so-called non-schizophrenic. So this is how the public are confused, because they think these things are just as biological as the others, and they're not. And they don't have the data to back it up. Despite in the DSM they'll claim schizophrenia has this biogenetic, there have been genes that have been detected for it. Data is very unreliable. It's not replicable, reproducible. So lumping all these things in together is just not, in my view, very accurate at all. And Yalom may have been convinced by selective data that he's seen that this is the case, but it's just not. It's not. It wasn't when he wrote this book several years ago, when it was still DSM-4, and it is not now. And the NIH and Thomas Insel, they admitted this basically. They basically said the research using this diagnostic stuff, it just doesn't yield anything really, so we're not going to do it anymore. They wasted billions on this stuff, didn't find anything useful. So certainly applaud Yalom for urging people to not rely on this stuff so much and avoid the diagnosis stuff. And often, yeah, it is the only reason for it is to get paid if you rely on insurance. And the insurance companies want a label to justify why they're covering someone. So a lot of it just comes down to bureaucracy. But in terms of actually helping people, these labels don't help me. And I can perhaps do another video in more detail, detailing how psychiatry as a whole makes my job much harder than it otherwise would be. But for now, perhaps that's enough. By all means, have a look at the book for yourself. Talk to you next time.